So now we'll move to questions and discussion. One question I'll start with, because it came up during our preliminary session and then again resonated in your presentations, was the issue of data. Where do you see the highest impact opportunities to invest in better data?
I'll start with that one. And thanks for the question, because really the idea of data. So Megan and I have approached things, this huge spectrum, and there's so many pieces to this spectrum. If we look at the acute injury data, the information that is very lacking from the smaller centers. We have very good injury data once they get to the big centers, but to find out, for example, what is happening at the smaller centers before they arrive at the trauma center, that's a huge area for system development, or even the pre-hospital data. And then at the other end is what happens when they leave hospitalization and go to rehabilitation. And then it starts getting into some of the stuff that Megan's talking about also.
Mm-hmm. Yeah, and I'll just add, thank you. I'll add that even at the larger trauma centers and the centers that contribute to the NTDB, we still have there's a lot of missingness when it comes to demographic characteristics. And there are also many racial and ethnic groups, for instance, are, pooled together versus separated into more inclusive groups where patients actually identify. So and we're lacking things like language, LGBTQ status, things like that. So so to your point too, we have a lot better data on the medical side, but not on the person or identity side at the acute care.
Thank you. We do have some hands starting to come up. So right now we have Tom and then Dawn.
Two fascinating talks. Thank you both. Rick, Tom Scalea from Shock Trauma. I would mention that your what if without the automatic notification is a pretty good representation of the Maryland trauma system. You guys should come visit. We'll show you around. What about better collaboration between the rural centers and the urban centers, sharing of protocols, intubation and hyperventilation, osmolar therapy, things that'll buy time. Or I know at least in Bozeman, there's a program where the trauma surgeons are trained by the neurosurgeons downtown to do at least burr holes and even craniotomies.
Dr. Scalea, first, thanks for the question. Second, thanks for being here. Third, I've been to your place and I'm a little bit intimidated even having to answer questions from someone that I look up to. I talked about this rural trauma team development course, and that was something that was initially developed as an educational thing that could be taken to the smaller facilities. The unintended consequence of that course has been all about relationship development between the centers. And that's what I really think, if we're just looking at the hospital part of a patient's care, having good relationships between the smaller facilities and the bigger facilities. And yes, whether that is sharing of skills, sharing of protocols, probably even more important is just simply the feedback, the performance improvement feedback that can occur between facilities that have an established relationship and a mutual respect, frankly. I think that's a huge area of opportunity in our system development.
And I would add too, if we can think about continuing that collaboration on through, the injury course, because of course it's really important as you're talking about in that critical pre-hospital time. And then as the patient moves through, because patients are going back to rural areas eventually. And so thinking about what are the rehabilitation services and that model that you're talking about of that ongoing collaboration, I think if we start it at the beginning of the course and then continue it, that's going to be really key for long-term outcome.
Yeah, Megan, as I was listening to you, I was trying to conceptualize as to how we would expand an already unbelievably cumbersome system to create specific services for underrepresented groups. That sounds incredibly complicated and incredibly expensive, or am I making this too hard?
No, I think you're very correct. It's challenging, and it is expensive, likely. I would say, I guess one of the things that others and have talked about, and I've thought about, is trying to do training and embed TBI informed care into existing community services. So some of what, like our patient panelists talked about earlier, they're going to providers in the community that don't know anything about TBI, right? And so there's just these huge gaps in knowledge, and they're getting different messages from different providers. And so, a place to start might be to educate the places where patients actually are already going, and where they feel safe from a culturally resonant, standpoint, where it's a safe space. Thinking about the work we're doing with transgender folks, and that they've expressed that, they don't feel safe going to large trauma centers or to large medical centers because of the, non-affirming care that can occur there. But there are trans-affirming centers. So can we provide that education in those centers where patients are going? Might be a place to start.
Thank you. Next we have Don, and after Don, we'll have Eric.
Yes, thank you so much, Corey, and thank you, Dr. Moore and Dr. Sidwell. I have a question as to the state of our knowledge about disparities with respect to African American, Latino, and Alaska Native and American Indian trauma outcomes. Do we know a lot already and have to act on it, or is there a lot more to study in terms of those disparities, outcomes, and care?
Mm-hmm. Yeah, there is certainly more to study, because as I shared, while that race ethnicity is the kind of most studied disparity in this area, and often the data is poor. As we were talking about earlier, what we have at a national level is there's a lot of missingness, and groups are often lumped together, or that's white compared to other. So I think there's a lot more, and then what does that really tell us, right, about a particular group and interventions that are going to work for a particular racial ethnic group or other identity. So I think there are limitations. I think there are known disparities for African Americans and Native Americans, Alaska Native, American Indian as well. And then there are also reports of resilience in certain outcomes for groups, right? So I think it's not all differentially negative outcomes, but I think there's a lot of work to be done.
Thank you.
Mm-hmm.
Thank you. Next we'll go to Eric, and after Eric, we'll go to Susan.
Thank you, Corey. And I want to thank both of the speakers too. Dr. Moore, particularly enjoyed hearing your talk. It was very informative, and I think it resonated with a number of us who are trying to put some coherence into what is, in large measures, not put words into anybody's mouth, but an incoherent system. And that was very, very helpful. Especially you're bringing in what we've started to think about as a biopsychosocial ecological model that enters in so much variability almost at every step. So that was very helpful. I just want to turn to Dr. Sidwell for quickly. I come out of the background of the DoD and the VA, and what you described really for the plight of the rural practitioner is very much now what is becoming commonplace within the Department of Defense. I mean, we are now in parts of the world, in all kinds of missions, humanitarian and otherwise, where we're very different from what we have become accustomed to. We no longer, as we were able to do in Afghanistan and Iraq, can guarantee a 60-minute round trip by a helicopter to a site of definitive care from a very remote site. That was our goal, and that was our achievement in both theaters of operation. But now we're in parts of Equatorial Africa and Asia and other places where it might be hours and hours, if not days, before people can be adequately moved along a chain of evacuation. To what degree, if any, are you working, or is there collaboration between the special operations community and the Wilderness Society in trying to forge best practices in this very austere environment? As Dr. Moore referred to a minute ago, one of the tough things we have is getting so many diverse opinions from so many different specialized groups. We've really called upon the Tom Scalias and and Marty Schreiber's and others on this group to help us forge a kind of common platform of practice under these very austere conditions. How are you working, if you are, with those other groups?
I'm not. Thanks for the question, Eric. I'm not quite sure how to answer that. Certainly, when we get beyond continental United States, okay, that's not something that I have any particular experience with. You are absolutely correct that the model that I have shown, that is the Joint Theater Drama System model, the PI that they do, and that's Dr. Schreiber, who I know is on the call here. That's the model that got presented from the military, and how can we adapt that to our civilian trauma system. In terms of kind of remote injury in the United States, it's all very local for development of that system. And whether some of the societies are involved or not, honestly, I don't know. But it's all a very local thing, sorting out rural Montana. How is that going to, those injured people going to end up getting to Bozeman for their care, for example? I'm not quite sure that I really answered your question there, Eric. I'm sorry.
No, it sounds like there's not as much collaboration in this arena than we've had historically in more of our fixed facilities, or our definitive care facilities, roll 2s, roll 3s out even in remote areas, where the military operates. I think your point, I'm not asking that you or anybody in your community have experience outside the continental United States. Quite frankly, what you described in Idaho, Montana, even Iowa, with all due respect, is as austere and remote as anything that you're going to find in Nigeria. I think that the point is developing best practices. If you have a sense that the rural communities, although local, would accede to a common standard of especially initial stabilization care and plans for evacuation, as Tom Scalia just talked about, is that something that would be accepted by those communities? Would they accede to something that resembles a common standard if there were cooperation across communities like special operations, like the Wilderness Society, in achieving those standards?
Absolutely. The small hospitals, the small facilities, they crave it. They absolutely, they're good providers. They want to do the very best. Part of the trouble, honestly, can be mixed messages that come from the urban trauma center. And I can use an example. Maybe there's someone at a small center who is obviously head injured, and then the neurosurgeon at the referral center says, well, what's the head CT show? Well, that probably isn't necessary to be done there at that facility. So some of it is mixed messages coming from the urban centers.
Great. Thank you. We are going to wrap up with Susan's question.
I think my question might be for Dr. Moore. You'd mentioned a lot of differences where data was needed and the care was very different, but I don't think you mentioned sex-based differences. You did mention cis-trans so do you have any data to tell us about the care that may be sex-based related?
Oh, that's a great question. There are studies about outcomes for men versus women, or maybe it's biological sex that they're actually talking about, because there's very few studies that are using gender in a trans affirming way. I think on that slide, I think there's only like 3 or 4. So there are, and I can get back to you. I can send you the articles on those. There's 89 that included sex, and there are disparities. So I can send those to you.
Okay, well, now we have the very fun job of saying thank you to our amazing panelists, and thank you, team, for the great questions that also help us advance our thinking about this. We now get a break, so I will let the NASEM staff let us know the specifics of our break.
I'll jump in first. Thank you, panelists. That was fascinating, and please do communicate any further details you have on the questions. Corey, thanks for your terrific job facilitating. Same to Matt for the earlier panel. You've all been very patient with Zoom time. We are going to take a 20-minute break. We'll reconvene promptly at 2:30 Eastern to get into our next panel, and we really look forward to it. So everyone, go take your break, enjoy it, and we'll be back at the half hour in 20 minutes. Thank you.